Most people still think LDL cholesterol alone defines cardiovascular risk. In many systemic diseases, this belief is misleading. Atherosclerosis does not wait for symptoms to appear. It begins early, remains silent, and progresses faster when the body is inflamed or metabolically disturbed. In these situations, ApoB particles behave more aggressively, even when LDL cholesterol looks normal. ApoB represents the actual particle that enters the artery wall. One ApoB equals one atherogenic particle. These particles cross the endothelium and become trapped inside the vessel wall. Inflammation increases this retention. Endothelial permeability rises, clearance slows, and plaque formation accelerates. Lowering ApoB early simply means fewer particles enter the artery and fewer plaques can form. Diabetes changes lipoprotein biology in a fundamental way. ApoB particles become glycated and more damaging. Small, dense LDL becomes more common, and remnant cholesterol rises. Together, these changes markedly increase vascular risk. In many patients, myocardial infarction risk approaches that of established atherosclerotic disease. In diabetes, early ApoB lowering is not optional, it is essential. Chronic kidney disease creates an environment where atherosclerosis accelerates by default. Oxidized LDL accumulates in the circulation. HDL loses its protective function. Coronary calcium progresses rapidly and is often underestimated. Plaques calcify earlier and behave more aggressively. Because of this biology, ApoB targets in chronic kidney disease must be lower than standard prevention thresholds. In autoimmune and chronic inflammatory diseases, inflammation itself becomes a cardiovascular risk factor. Cytokines increase LDL oxidation and promote endothelial adhesion. The arterial wall becomes more vulnerable to plaque formation. Atherosclerotic cardiovascular risk rises by 1.5 to 3 times. LDL cholesterol alone underestimates this danger. Lowering ApoB helps counterbalance the vascular effects of chronic inflammation. Metabolic syndrome and fatty liver disease often hide a significant ApoB excess. LDL cholesterol may appear acceptable or even normal. However, ApoB particle number and remnant lipoproteins are frequently elevated. The liver overproduces atherogenic particles, allowing plaque to develop silently. Measuring ApoB, rather than relying on LDL cholesterol alone, reveals the true cardiovascular risk. Lifetime exposure to ApoB determines cumulative plaque burden. In familial hypercholesterolemia, arteries are exposed from childhood. Cancer therapies damage the endothelium and accelerate vascular aging. HIV causes chronic immune activation, even when viral replication is suppressed. In all these conditions, time matters. Delayed intervention allows irreversible arterial disease to develop. When systemic disease is present, LDL cholesterol alone is not enough to guide prevention. ApoB should be managed like blood pressure, continuously and proactively. Earlier treatment leads to lower ApoB levels maintained for longer periods. In many patients, combination therapy is required to reach effective targets and meaningfully slow plaque progression. Do not wait for LDL cholesterol to become high. Systemic disease multiplies ApoB-related risk. Plaque forms long before symptoms appear. Early intervention protects the arteries and changes long-term outcomes. Normal LDL cholesterol does not mean low cardiovascular risk.